Hello, and welcome to our webinar today, Screening, Brief Intervention, and Referral to Treatment, or SBIRT, a brief clinical training for adolescent providers. I'm Tracy McPherson. I'm going to be your webinar facilitator today, and if you have any questions about the content or need any additional information about any of the materials that are mentioned today, or just have some general follow-up questions about the work we're doing, you're welcome to contact me at the email address shown on your screen at any time. This webinar is produced in partnership with NORC, the Brief Intervention Group, or the BIG Initiative, the National SBIRT ATTC, NADAC, and SAMHSA. This webinar today is part of our 2015 SBIRT webinar series. As you can see, we have a full lineup running through August of 2015. We have a number of topics that if you are interested today in the adolescent topic, you will definitely be interested in several others that are coming up in April and also later in August, focusing on teens and young adults and college age students. In addition to that, we're going to be having topics on older adults as well as SBIRT and ACA. And also exploring some new topics for us this year, looking at military culture and the role that SBIRT plays with veterans and active duty. Also, a special population series that we're going to have later in July, which is on LGBTQ populations. You can go to our hospital sbirt.webs.com website, and you can download this brochure as well as sign up for any and all of these webinars. All of the education is free, and we're offering CEs to you for free as well. Also, all the PowerPoints and recorded versions of anything you see in the lineup will be available to you. So today's webinar will also be posted there, a recording of it, as well as currently you can access the PowerPoint slides. We'll also have a link to the CE quiz. And again, this particular webinar will also, you'll be able to receive free CEs after completing the quiz. And then you can find a web page dedicated to this particular webinar at our hospital sbirt.webs.com/adolescent-providers webpage. Throughout the webinar, you'll have the opportunity to ask questions. We'll have a Q&A period at the end, but as questions come to mind, you are certainly welcome to use your questions pane. Up in the right-hand corner, you will find the Go to Webinar Questions pane. You can type your questions in there. Some of them I'll be able to answer behind the scenes. Also, if you have any technical questions, you'll also we'll be able to enter those there as well. And Misty will be helping us to answer the technical questions. She's our technical facilitator today. And you are welcome to put any of your questions about content or technical aspects there, and we will try to answer them along the way and save time at the end to get as many of those other questions answered. We have two terrific presenters today. It's my pleasure to introduce Brett Harris and Shirley DeStefano. Brett Harris is a research scientist, and she's specializing in adolescent screening and early intervention at the New York State Office of Alcoholism and Substance Abuse Services, or also known as OASIS. Dr. Harris has led screening, brief intervention, and referral to treatment implementation projects in school-based health centers and currently co-leads a nationwide adolescent SBIRT learning community. She serves on the SBIRT Advisory Committee for the National School-Based Health Alliance. Dr. Harris recently completed her dissertation on school-based health center program directors and clinicians' attitudes and perceptions which facilitate and impede the adoption and implementation of SBIRT in school-based health centers, and is using the results to inform a strategy to expand and sustain SBIRT in the network of New York State school-based health centers. Dr. Harris earned her Doctor of Public Health with a concentration in health policy, management, and behavior from the University at Albany in 2014, her Master of Public Health from the University at Albany in 2008, and her Bachelor of Science in Human Development and Social Policy from Cornell University in 2006. I'd also like to introduce Shirley DeStefano. She's a project manager in the New York Screening, Brief Intervention, and Referrals to Treatment, or New York SBIRT grant for the New York State Office of Alcoholism and Substance Abuse Services. She's been a project manager and an evaluator for several federally funded grants for over 25 years, with prior experience in clinical services and management information systems. She is an OASIS certified motivational interviewing trainer. In her previous role, she was the project evaluator for the FASD Initiative Project, Project Choices, and she developed and conducted training and motivational interviewing sessions. She holds a Bachelor of Arts degree from the College of St. Rose in Albany, New York, a Master of Arts from Hood College in Frederick, Maryland, and an advanced certificate from Georgetown University in organizational development. So it's my pleasure today to turn it over to Brett, who's going to start us off in talking about a brief clinical training for adolescent providers. Welcome, Brett and Shirley. Brett, I'll hand it over to you.
Great. Thank you, Dr. McPherson. So Ms. DeStefano and I would like to thank you guys for inviting us to deliver this webinar, and we're very excited about the number of people that have registered, and we see that there is a great interest in providing SBIRT for adolescents. So today we'd like to give you an introduction on some clinical skills for delivering SBIRT with adolescents, but also, we'd like to recommend doing some practice on your own and with your staff for some role playing. So unfortunately, we don't have the opportunity to do that on the webinar, but we will give you some introductory skills. So just to begin, what is SBIRT? Just to address, I'm sure there's a whole spectrum of people on this webinar. So from the beginning, SBIRT is an evidence-based prevention and early intervention model to address the full spectrum of substance use. So really what we've been doing so far is prevention services and treatment services. So we leave out a large number of adolescents that may be at risk for substance use disorders but are not receiving services. And of course, this is also a prevention model to address those who have not yet initiated, to prevent initiation as well as providing referral to treatment. This occurs in non-substance use treatment settings, so primary care settings, school-based health centers, and some other sites, also schools, juvenile justice settings, emergency departments, employee assistance programs. And so it provides screening, which we'll get into with universal screening using a standardized tool to identify the adolescent on the spectrum of use, and then based on that screening score, providing a brief intervention using motivational interviewing techniques, and for those when it's necessary, providing a referral to substance abuse treatment. Next slide. So substance use, why we're going to be working with adolescents, and we think this is important, is because substance use is associated with many things, including risky sexual behavior, transmission or contraction of sexually transmitted diseases, pregnancy, motor vehicle accidents and other accidents and injuries, some chronic diseases, substance dependence. The earlier that an adolescent begins using substances, the more likely he is to develop a substance use disorder later in life. It's also associated with depression, fights, criminal and delinquent behavior, and also has association with school performance, misconduct, and dropout. Next slide. So how does SBIRT address student needs and adolescent needs? So one is that it reduces alcohol and marijuana use. So some of the research, while preliminary, there is some research showing that it reduces alcohol as well as marijuana use in primary care settings. and some evaluation studies show that as well for school-based health centers and community health settings. It also prevents initiation of substance use. So for those who have not yet begun to use, it has prevented them from starting, and when compared to a treatment as usual group. The prevention aspect of SBIRT saves your organization money. It shows that for every $1 saved, spent, $4.3 is saved. And also providing it in certain settings, especially in medical settings covered by HIPAA, it provides confidentiality for the students, and then providing SBIRT in other settings where they frequent often, such as schools or school-based health centers, to provide convenience. SBIRT is also a good fit for adolescents, especially with the motivational interviewing portion of the brief intervention. It doesn't force an adolescent to admit wrongdoing. Instead, it lets the adolescent guide the intervention and have some autonomy in the process. Also, what some studies have found is that adolescents are satisfied with SBIRT, that they feel that they don't feel that they're judged. They feel that they report that they've received good advice and that they're likely to follow through with the advice. And also, in addition to the research, we've had some experience conducting this intervention in school-based health centers, and have heard from the providers about this also being working well in their settings, and that adolescents are willing to report this information. And of course, this is a recommended service by the American Academy of Pediatrics. Next slide. So just getting more into depth in the core clinical components of SBIRT. As I mentioned, screening. So this is screening, universal screening using a standardized tool. So using this tool helps to quickly assess use and severity of use. And then the standardized tools, especially the one that we'll be addressing shortly, gives you a way of scoring the screening so that you know what level the student, the adolescent is on the spectrum of use, and how to deliver the brief intervention based on that score. So the brief intervention is a brief motivational and awareness-raising intervention, which is given to risky or problematic substance users based on that screening score. And don't forget that people that are not using at all are also benefit from encouragement and reinforcement of the positive behavior. Brief treatment is really additional sessions of brief intervention, which emphasizes motivation to change and client empowerment. It's provided to moderate to high-risk users. So oftentimes we do recommend, based on screening score, that adolescents are brought back for additional sessions so that continual monitoring of behavior change can be conducted. And then referral to treatment is referrals for specialty care for those with substance use disorders. Next slide. So as I mentioned, there is a whole spectrum of use among adolescents, and this slide shows it's highlighting the moderate users. This is about a quarter of all users, 25% highlighted in blue here. And then there's 65.7% of non-users and 4.4% light users. And then there's 5.2% which are dependent. So you can see those two bars on the right and the one bar on the left are what has routinely been addressed in the past for prevention and then treatment. So the blue bars, the moderate users, have not gotten services historically, and SBIRT is focusing on providing services for these moderate users, as well as the non-users or light users, as well as dependent users. Next slide. And brief interventions, as I said, can be used in multiple settings to address those mild to moderate users. And schools, juvenile justice settings, pediatric clinics, school-based health centers, and mental health clinics. And then, of course, there is intensive treatment for those who are in need of services that have symptoms of substance use dependence. Next slide. So when we introduce SBIRT, we find that some providers think that they're already doing it. And it is true that a lot of providers are delivering some components of the model, but not all of them in combination. So what we like to stress is that providing the screening using the standardized tool, the brief intervention, and the referral to treatment it's the complete SBIRT model. And by using SBIRT, you can make it your role to address adolescent and student substance use. You can use standardized screening tools such as the CRAFFT, which we'll be introducing, to correctly identify substance use problems and promote early intervention. You can also increase your confidence in addressing substance use, and you can more effectively help students and other adolescents to reduce their use. Next slide. So, you wonder, I keep mentioning standardized tools, and there are a lot of general health assessments which are used in primary care settings and school-based health centers that do ask questions about substance use. But why a standardized tool? Because it provides an evidence-based algorithm for the provision of appropriate services. And it takes the guessing game out of identifying problem substance use. So by using a standardized tool, it results in higher detection of problem use and is a best practice. So as I mentioned, if you use informal screening, you just ask a few questions, or a larger health assessment such as the GAPS or the RAFs or the HEADS, it does not provide these features. So it is more likely that a provider will be relying on clinical impressions, and which means that from one provider to the next, adolescents may be identified differently, and some adolescents may not receive services that they need. Next slide. So now I'm going to introduce the CRAFFT Screening tool, and this instrument has been recommended by a number of agencies, and we recommend to use this tool. It's a quick and easy tool, but of course there are other tools and questions to be asked. But for this training, we're going to focus on the CRAFFT, which is a validated screening tool for use with adolescent patients. And it's very handy because it provides, it's a screen for both alcohol and other drug problems at the same time, so you do not need two different screening tools. It consists of two parts. Part A is considered a pre-screening portion, so it has 3 questions about past 12-month use. And then Part B has 6 items, which are the acronym CRAFFT. And it also, as I mentioned, provides a scoring algorithm, which then provides you information about how to deliver a brief intervention. A positive CRAFFT means that a student or an adolescent should be assessed for alcohol or drug abuse or dependence. Next slide. So this is the CRAFFT screening questions, and this is a tool that shows you, this form shows you the skip patterns, which I'm going to be addressing on the next slide. But I just wanted to present this to give you a visual. It shows you the Part A. This has the information for the past 12 months, really asking about any use, alcohol, marijuana, or any other drugs to get high. And then the Part B, as you can see, and CAPS are the acronym CAR, relax, alone, forget, family or friends, and trouble. Next slide. So Part A, now to delve deeper into the CRAFFT. During the past 12 months, did you drink any alcohol, more than a few sips, smoke any marijuana or hashish, use anything else to get high? So anything else includes illegal drugs, over-the-counter and prescription drugs, and things that you sniff or huff. So if a student answers no to all of those questions, there's still one question that you need to ask in Part B, and then you'll be done delivering the screening, because the CAR questions not only assesses about driving while intoxicated, but it also assesses riding in a car with someone else who is driving while intoxicated. If yes is answered to any of those 3 questions, then you must ask all questions of Part B. Next slide. So here in red, the letters and the words that correspond with letters are highlighted. And I'm going to go over these questions one by one. So question 1 is the car question, and this is the one that's asked of all adolescents. It reads, have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? And remember, if the adolescent had answered no to all the 3 Part A questions, this is the only question that is asked, and then the screening is complete. So number 2, of course, if the student answers, if the adolescent answers yes to the car question, then there is a specific brief intervention, brief advice that's provided just to address the driving risk. Question 2, do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? 3, do you ever use alcohol or drugs while you were by yourself or alone? 4, do you ever forget things you did while using alcohol or drugs? 5, do your family or friends ever tell you that you should cut down on your drinking or drug use? And 6, have you ever gotten into trouble while you were using alcohol or drugs? Next slide. So this is very easy to score, and each yes is added to produce the screening score. So for CRAFFT scores of 0 or 1, this is called a low-risk adolescent. So for someone that scores in this range, provide positive feedback, brief advice, and encouragement. So really, for people that aren't using at all, you just reinforce that positive behavior. And for some use at low risk, but very low risk, you just find out a little bit about the background of this adolescent and just encourage continued good behavior so that they can continue achieving those goals. For CRAFFT scores 2 to 6, this is a positive screen. Any score 2 or above is referred to as a positive, and these are high-risk screens. So in this case, you must assess for acute danger or signs of addiction and provide brief intervention. Depending on the screening score and the brief intervention, consider providing referral to treatment. For CRAFFT scores of 5 to 6, this is considered very high risk, and you want to assess for acute danger and signs of addiction and provide brief intervention with the goal of having the adolescent accept a referral to treatment. Next slide. So just to give you a little bit of information about binge drinking, because that's something in particular that we want to address with adolescents. It is an adolescent age and gender specific, so it's not just listed for adult male and female, but it is specific for age as well. So for girls and boys ages 9 to 13, 3 or more drinks in one occasion is considered binge drinking. And then for girls 14 to 17, it's also 3 or more drinks. For boys ages 14 to 15, it's 4 or more drinks. And then boys ages 16 to 17, it's 5 or more drinks, which is the same as for adult males. Next slide. So at this point, I'm going to hand it over to my colleague, Ms. Shirley Stefano.
Hi, welcome. Thank you for joining us, and thank you, Brett, for that wonderful introduction. What we're going to be talking about in the brief intervention is that there's several different types that people talk about, and we're going to be talking about a specific one. So I will get into this and address first, what is the role that you play when you are the interventionist yourself, and what are your tasks in this role? The first thing, which isn't on here, and I always think everybody remembers this, but I'm just going to bring it up, is that we always have to remember the issue of confidentiality is very critical with all adolescents, and letting them know that when they're speaking with you and doing the intervention or providing any of this information, that they understand the level of confidentiality. As Brett mentioned, there's the HIPAA, but there's also building of the trust that happens during this process. So the first thing you're going to do when you're sitting down during the engagement process is look at where they are in stages of change, and look at what you might be able to do during that intervention with them. And the next one is that it's a non-confrontational interview, And it uses motivational interviewing, and all parts of motivational interviewing fit very well into the intervention itself. And as Brett said earlier, fit very well with the developmental stage of the adolescent in the responses to their search for autonomy, their ability to grasp what you're saying, and also that you are using it from a strength-based focus. Next slide, please. This is another model of what stages of change are, and what you're looking for within each of these particular phases of change. We talk about the pre-contemplation, and that means that they're not really thinking about it or even considered it, and you will find maybe some of the younger end of the spectrum of 12-year-olds who really haven't thought about it very much. But a lot of people are really in contemplation. They know that there's drugs and alcohol going on. They may have tried some, but they're aware of it. And when you're getting into it, you're looking for what they're going to be thinking about changing. And the forever, ever part of this stage is the ambivalence. And again, motivational interviewing fits this well with this, because that is one of the prime tests that you do, is to help resolve the ambivalence in normal process. Determination, you're looking at finding a way to help them identify what types of strategies they can use, and motivational interviewing again fits in very well because of the motivational interviewing 3, you're looking at engagement and focusing and evoking from them where they're going to be going. Action stage, this is where you hopefully within this very brief intervention are going to move them to a point where they can actually start thinking about change and maybe be able to eliminate some of those behaviors that they can identify and work towards the goal of maybe not using any substances whatsoever. Maintenance, again, is where you hope, if you're working with them for a while, that they'll be able to do it. And again, some students are going to be at a stage where they're ready to move and go on. And again, you'll begin much quicker with them, and you'll be able to use other forms of motivational interviewing strategy to help make that commitment stick with them. So what you're hoping for is that in maintenance that you can develop with them that they are into a pattern of either reducing and eliminating any of the use and behaviors that will put them in any kind of risk or jeopardy. And reoccurrence here is when there are slips, and there are probably times when they weren't able to continue doing what they're doing. They're adolescents, they're still developing their prefrontal cortex, and all of those executive functions aren't really well set with them just yet. So you can very quickly assess that when you start talking with them, and that's done in the next slide, please. The brief negotiated interview, which is the model we use and we train with, and it is a specialized brief intervention that has been used in medical settings, and again uses the foundational work of motivational interviewing and many of the techniques that you're familiar with, such as asking open questions, doing affirmations, doing a lot of reflecting. And what we found is that it's demonstrated to be effective, and it facilitates a variety of behavioral health, not only with alcohol and drug use, but with things such as dieting and other positive use, such as quitting smoking. It also helps health care providers explore these behavioral changes in a respectful, non-judgmental way in a defined period of time. And here's where MI comes in, and it's very much into the motivational interviewing spirit, which, shows that you are respectful, you do not label, you're also able to elicit from the client those particular methods and behavior change on their own. And it's designed to elicit reasons for change, and that's, again, very much what MI does. It evokes from the client those reasons within themselves, their strengths, that they'll be able to take those steps necessary to do this. And the particular brief negotiated interview that we use is actually in the form of a script, which again allows the provider to move through very quickly. It has key questions to ask, and it looks for key responses. And again, while it's a script, because we've been said, oh, those words don't sound quite the way I would say them, and that's fine. But when you're learning this and applying this, you'll slowly begin to find those words and those phrases that help you understand how to say what needs to be said in this very brief period of time. Next slide, please. Brief negotiation interview starts out with, as we would say, the engagement period. That's the developing of the rapport between you and the individual. And again, it uses a lot of the motivational interviewing statements and questions. And, you know, it's sitting down with the adolescent. And without this initial building of the rapport, in engaging with them and having them engage with you, there's really not going to be an interview that takes place that can be meaningful to both the adolescent and the interviewer. So you start out slowly, depending on, again, in the circumstances. Do you know the individual? What do you know about the individual? Have they been in before? Or is this a brand new person coming to you who really doesn't know much about you or the place where you are? So you take your time. You begin, and as you see here on the page, you know, it says, you know, let's get to know each other a little bit. I'd like to learn a little bit more about you. And it might be something like, well, you know, you come to school, so what's the day like for you? Do you have special subjects that you like? Can you tell me some of the important things about what you're doing now in your life? I see you came in for a physical for football. And can you tell me how long you've been on the team? Or is this your first time? Again, asking open-ended questions so that they can explore that with you, reflecting back to them what they're telling you about, yes, I've been going on the team. I'm a place kicker. It's really exciting for me. For a girl, it's no, I've been on the cheering squad, or I want to get on the cheering squad and they need to have this. I'm part of the band. Whatever those particular things that are relevant to their life and they tell you about would be good to reflect back to them, affirm what they're doing, using your reflections, summarize what you're talking about. And because they've come to you at this point, it means that they probably have been using the substance. And so once you're able to engage with them and feel that you're making that connection with the adolescent, it's the time now to say, okay, would you mind if we take a few minutes to talk about some of your comments that you made on the screening instrument? And it says to me here that you have been using alcohol, or that you've started experimenting with heroin, that you have tried some, went to a couple farm parties. And so can we take a few minutes and talk about it? This is also exhibiting your respect for the individual and that you're recognizing their autonomy. That opens it up to them because you're asking, would it be okay? Would you mind? That's asking permission again. Plays right into what you do with motivational interviewing. So then you start talking about it. The next stage in this brief interview is you start looking about what's so good about it and what's not so good about it, and you start exploring that. You can ask very quickly, I'd like to understand more about why you're using alcohol, and you're telling me that you know, you're doing it a lot of the time on the weekends, and so what's so enjoyable about your use of alcohol? And so they start telling you that it's a time that they can spend with their friends, that it's time where they start having a party, and it doesn't necessarily always mean alcohol and drugs, but most of the time it does. So that's the good thing about it, that they're enjoying it, they're with their friends, they're having a good time. And so you say, well, what else about it? Well, it makes me feel good. It makes me feel happy. I don't always feel happy. so you can explore that. So what else? And then they tell you a little bit more about why it is, and you can also then say, so, okay, but can you tell me some of the things that are not so good about your use of alcohol? And that conversation can take in things such as, well, some mornings I wake up and I really don't feel that good and I miss school, and then that gets me in trouble with my parents. And okay, so that's one of the things that's not so good. Was there anything else? Well, yeah, I was at a party last weekend with a guy I kind of like, and I'm sorry. The next thing you know, I had sex with him, and I'm really not too happy about that because we didn't use any protection. So you can, at this point, start talking about what that meant. And so could you tell me more about that? That made you feel uncomfortable, you were scared. Without the protection, you're afraid you might become pregnant, or you maybe have been exposed to STDs. So what do you think you can do about that? What are your thoughts about any of this that you've done? And reinforce anything at all that you're hearing back that the person, the student, is saying that they're going to make a change. What was positive about it? Well, I came here today to be tested. Well, it took a lot of courage for you to come in today to be tested for the STD or a pregnancy test. So you're reinforcing that. So then we get into the next slide, please. This is feedback. And you have information now. You can provide, and you ask permission by saying, well, thank you very much for letting me understand a little bit more about what you've been using and doing, but I'd also like to talk to you about what are some of the guidelines for drinking, and would you mind if we start to share some of them with you now? And you can start to provide that because they've given you information, and again, it could be the information that they need to know about what are some of the risks, what are the guidelines, and one of the things that a lot of kids and adults don't understand is, for instance, they told you that they were out at the party and the big thing was is how much could you drink in the shortest period of time. And so you repeat what you said, 3 or more drinks in a 2-hour period is called binge drinking. And actually when people do binge drink, it's possible that they can become very ill from it, and that's called alcohol poisoning, or you can be at risk for some other injuries that may have happened because of your intoxication, and other health problems that might be important here, such as becoming, if their use is very high, that they can also start having organ problems and failures because of their use. One of the other things is they talked about blackouts, for instance, that it could they couldn't understand what it means, and you can say, well, during the blackout, you know, you've caused some injury to your brain because of the amount of alcohol that you put into your system. Or if they talk about, and I am spending a lot of time on alcohol because that is the substance that most adolescents use, but again, they can be using more, as we are hearing, of the heroin and certain types of prescription drugs that are used prescriptively. So when you're going through this, one of the things you always want to do is, again, using MI, ask them, so what do you think about this? What are your thoughts about what have you been doing over this period of time? It's important because it says, tell me, have you heard what I've said, and do you have additional information that you need from me? Yeah, I thought about this before could be their response, but I never really knew that that would happen to me. It kind of scares me a little bit that I had that happen. And then you reflect back on that to them again. So it sounds to me as if with with this happening to you, that it wasn't positive for as positive an experience as you thought, and that the partying may have gone too far, but now you're saying that maybe you can make a change about that. So again, reflect back. Is that what you're thinking about? Are those any of your thoughts? Next slide, please. Readiness to change. After you've engaged, you've given them some time to think about it, both what was good about it and what was not so good about it. You've given them an opportunity to get more information and ask for more information. You want to, again, it isn't just a matter of doing that, which is what happens in a lot of cases. Now that you have the information, go out and do it. Well, adolescents and most people aren't ready to do it then. You need to check in with them and have them figure out for themselves just where they are with a problem. And one of the quickest way to do it is to use, again, one of the things that we use in motivational interviewing, a ruler. And on the slide you see that there's a readiness ruler here, but there are also two other rulers that can be used, again, depending on where your conversation goes. And one of the ones that might be helpful is how confident is the individual. Because confidence with adolescents can be a very fluid state. They might feel that they can go out and run that mile in much less time, but it may not be, they may not be ready to actually do it that way. So the confidence ruler, the importance ruler, and the readiness ruler are three of the rulers that can help you get the individual ready to change. And finding out how confident they are to do it on a scale of 1 to 10 will give you an idea of well, okay, you feel that you were 60% of the way there if they pick 6, and they might feel that they have the ability to do it as well through because it's important to them. It's important to me because I'm an 8 on this, because I know if I continue to drink like this, then I might risk the scholarship. I might not get the grades I need. It's important to me because my parents will be very disappointed in me. But those are, again, the types of rulers. And, of course, the readiness ruler, which is saying, okay, I feel pretty confident that I can do it. I know it's very important to me. And you're enhancing the motivation to change by bringing it to their attention. Okay, how ready would you be to say, instead of going out on both Friday and Saturday night, or even Sunday, to cut back to maybe one night on a weekend? And so how ready would you be to do that? Well, I think I'm probably at a 7, maybe 7.5 I could do it. So you're 75% of the way there, and you think that would be pretty good for you. And that's the kind of information an adolescent would look at and feel fairly confident in it. It's a pretty concrete piece of information that they could easily grasp. Visioning change in their life is also important. Even though adolescents tend to live in the moment, it's also important because if they do say, well, I know that making this change is important and I can do it, I also need to do it because of my grades, because of my my scholarship, because I don't want to fail that course. And one of the ways of saying it is, why weren't you at a lower number, like a 1 or 2? Well, because I know that I have the knowledge to pass that test, and I know that I'm at a 7 or an 8 because I can actually study for it, and I know I can study better for it if I don't have that alcohol, or if I don't come in and be hungover the day of the exam. So, next slide, please. When you've actually gotten to the point where you've talked through it, you understand and they understand where they are, it's good then to start saying, so what do you think about coming up with some steps? What do you think we'll be able to do right now? Do you feel that, for instance, there will be a way for you to say, I'm only going to be going out one night a week, and then you would actually sit down and write down the steps? Well, those are great ideas. We can actually sit down now and take the time and, again, using open-ended questions, doing reflections, doing summaries here is an important part because they might often come up with some challenges that they didn't have when you first started talking and getting the feedback. And that's okay too, because this is an iterative process in which as you learn more about the individual and as the individual looks more at the situation they're in, they're going to come up with different ways in which they might not be able to do it. So you make those summaries, you do that reflection, and you always go back to the strength-based position of looking at how they've been able to do things before in the past and how any and all of these changes can be beneficial to them. And again, within your interview process, coming up with the actual steps and keeping them simple for the adolescent, or even having the adolescent write them down while you're talking together would be also most helpful. Next slide, please. You create the action plan, and when you're doing that, you're always thinking, how can you stay healthy and be safe while you're doing this? Those are two key things, because adolescents, as we all know, are really high risk takers, and they sometimes think they're capable of doing more than they can. Keeping it within a safe and risk-free environment would also be very helpful. So, for instance, what will help you to reduce what you're using now, and how can you do that safely would be something I would say. And asking them, again, be very explicit and concrete in what you're asking them, your use of alcohol, your use of heroin, the amount of time you're using them, over a period of time, what kind of reductions can you do, and keeping in mind that these challenges will keep coming up. So tell me about a time when you were able to overcome those. And even though they have had lived for maybe 12 to 21 years, they've had a list of things that they've done in their life that they feel good about. And again, by doing the reflective listening, by doing some summaries, asking open-ended questions, you help them elicit and evoke from themselves what they've been able to do and how they've been able to do it. And again, which of those are available to you now? Making it in the present time so that they know that it's there for them and that there are ways that they can overcome any of these challenges that they've had. Next slide, please. So at the very end, we're looking for a way of bringing this all together for them. Remember, this happens very quickly, within 15 minutes, sometimes a little bit more, depending on what they're using. But you're always saying, okay, let's summarize now what we've been talking about, and you let me know if there's anything that you want to change to make sure that I'm talking about those things that you think are important. Reinforce their ability to do it, that they have been and have showed you and talked about how they've been able to overcome challenges. You can provide them with additional information. You can actually have that plan that they have. And if they did and you were able to come up with the steps in a plan, please go through them, look at each of the steps, go back and double check with them. You know, is this how you see it now? Is there anything you would like to add to it? This is a brief negotiated interview, but with some of the cases at the higher ends of the scale, we know that we need to take some additional steps with them, and what we need to do is always remember that if you need to bring them back for a follow-up, we know that multiple brief interventions have been very successful for the adolescents, and that they make greater progress with them. Next slide, and that they're able to come up with some maybe better solutions during that period of time, and that they are a great resource that maybe they haven't even tapped into themselves about what they can and can't do. Next slide, please. Referral to treatment, and these are just very broad guidelines because some of you have policies and within your clinics, within your organizations about how you handle them. But remember that within this population and who we're looking at, if you remember that triangle that Brett talked about earlier, there are going to be a relatively small amount of youth of adolescents who are actually going to need a referral to alcohol and drug treatment. And one of the key things, again, remember the confidentiality, remember what we need to do and that the adolescent understands it, though, that what we know works and works best is to get a parent involved. And again, with the idea of working through this with the adolescent and checking out always the safety factor. You know, what do you think would happen if we were to ask your parents here? Is there any threat of violence? Is there any indication of current use or any other types of issues in the house? Would it be safe to have the parents involved? But we also know that successful treatment with adolescents usually does involve parental consent and parental involvement. Everyone who's working in the field or in an integrated behavioral health and situation should be able to have at least one current referral agreement. We think maybe agreement or an MOU, something of that nature, can be very helpful in that you have a relationship with a treatment provider, one who understands your clientele, one type of provider who will be able to be accessible fairly quickly in circumstances where the type of referral you're going to make will be for an adolescent who needs immediate hospitalization. We again support the idea and recommend that you do have an agreement of that kind. And that the site should also understand the services of what the local providers are doing and be familiar with them. That is one of the things we try to do by bringing our school-based health centers together with the treatment providers. So both sets of staff have an understanding and an appreciation for what they're doing and also for what they're recommending for the adolescent. Next slide, please. And I would just like to do a brief little summary of what we've been talking about, and that's, again, screening all of your adolescents come into your program, providing them with a validated tool that will help you so you can use it without much guesswork. Always, as we've just talked about, find the appropriate level of intervention based on the results. And if you do have electronic health records, make sure that you're using them and making sure you have the plans and follow-ups so that you can follow their progression through regular intervals. So I'd like to hand it over now to Brett so she can tell you what we have been doing. Thank you.
Thank you, Shirley. I just wanted to wrap up by saying, as I mentioned at the beginning, this is a brief introduction to the skills of SBIRT, and it's a lot to take in. So please be sure to practice, do some role playing with your colleagues, and then do some practice on your patients and get used to it. It will take some getting used to and just to develop the confidence, but we believe that this is, it's been recommended by the American Academy of Pediatrics, and it can actually help your patients to make some changes. Also, we recommend seeking out some motivational interviewing training so that you have those skills to conduct the brief negotiated interview. Also, it's very important to understand that you're not alone, that other sites have implemented SBIRT and had positive results. And if we had more time, it would have been nice to have a case study from a site that has been doing this. But there will be some webinars in the coming months that will provide this information. So hopefully you'll be able to attend. But what we do want to stress is that from our experience that we've had some sites implementing SBIRT with adolescents with positive results, and what we found is that it does increase the identification of youth. So just by using the standardized screening tool, more adolescents are being identified on that spectrum of youth. It's also standardizing substance use service delivery. So as I said earlier, providers do tell us that they feel that they are doing some of this already. And what we've heard is that once they've been trained and have been delivering SBIRT, that they felt that this SBIRT has standardized the way they've delivered these services and hence making it easier for them to deliver. It also increased referrals to co-located mental health providers and sites that had those staff available, and also that students and staff were satisfied with the services. And in New York State, as in a number of other states, screening and brief intervention are reimbursable through Medicaid as well as commercial insurance, so that there is some revenue available for billing. So anyway, I want to thank everyone for attending this webinar, and at this point would like to hand this back over to Dr. McPherson.
Great. Thank you, Brett, and thank you, Shirley. That was a really nice introduction, and I really appreciate you diving into the CRAFFT and really diving into the brief intervention and providing some scripting. I think that's really, really helpful. I can tell by the questions that we're getting and the responses that it really is very nice to kind of go into that detail to help people walk away with some tools, some very specific things they could potentially use later today or tomorrow. So thank you very much for going into that. Let me start with a couple of questions related to the CRAFFT screening tool, and I think you may be able to help some folks with. The first question, in terms of the actual scoring or presenting the items related to if the adolescent has been in a car with an individual, does that individual include a parent? So if the adolescent says, yes, my parent, I've been in the car after they've been drinking, would that item be valid to imply including the parent? Does that affect the scoring in any way?
That question refers to anyone. Has the adolescent been ridden in the car with anyone who had been driving while drinking or while high on some substance? So it wouldn't. I mean, it wouldn't make the score, greater or less. It would be the same. It would just be a yes response if a student or the adolescent had been in a car while a parent had been driving while drinking or while intoxicated or while high on some substance.
Great, great. Thank you. Another question related to the CRAFFT and parents, and I get this question myself quite a bit, is there a parent version of the CRAFFT? Something that the parent's asking or answering the questions about their teen, or is there another tool that you're aware of that you would administer to parents to respond about their teen?
We're not aware of any tool that actually asks the parent to respond, or what a screening tool for parents regarding their adolescent substance use. Well,
that confirms the answer that I give. I'm also not aware of a validated tool, and I do a lot of training as well. So it seems like there might be a potential opportunity out there somewhere. The next question we have is also in regard to the CRAFFT, says in regards to the workflow, is the CRAFFT being completed during triage with the parent present? That's the first question. Or at the time of check-in, or are there other points in which this is being administered?
It really depends on the workflow of each site and what fits in best with them. It's not conducted with the parent in the room though. That was very difficult for an adolescent to provide truthful responses, and they are ensured confidentiality. So the parent is not in the room, but it can be provided either self-administered or a face-to-face interview. It can be done during registration, with a bunch of other forms on a clipboard. It can be done on an electronic registration, a computer with a bunch of other forms. It can be done by a medical assistant. It can be done, by a nurse practitioner, physician assistant, or even a physician in the either during the exam. So it can be done at multiple different times, and it can be done in multiple different modes of administration. But it really depends on the site, and it's very helpful that prior to getting started with the intervention and really implementing it, that you take a look at your workflow and sit down with all the staff at the site and figure out what fits best. And it might take some trial and error as well. So once you implement, you might feel that it doesn't, you want to fit in differently, and then you make changes at this point.
Hi, this is Shirley. We've seen it done, and actually seeing it play out now, that some of the providers will have the pre-screening done and in a written form or on a computer, and then have the other 6 questions asked in an in-person interview. The only thing I would say is that whenever you're bringing the adolescent in to go over the results, that you do take the time within the interview to go through the questions, make sure they understood them, clarify any points, and use that time to, either do the brief advice, do the strength-based approach, but go through the questions with the adolescent, especially if there's any yes, and if there's the car question, you need to do that part of the feedback there. Thank you.
Thank you. And so here's another question about the CRAFFT, and as the use of marijuana and different forms of marijuana and different types of foods and beverages perhaps become more of an option. Some of these tools were developed sort of prior to sort of the emerging methods and ways in which marijuana has become maybe more popularly used in some places. So this question is about whether the CRAFFT has caused some confusion for clinicians or other providers, as it only asks about smoking marijuana or hash. And what about using it in foods or teas? Is it okay to ask the question differently?
We haven't found that it created any confusion. We've noticed actually with the sites that we've used the CRAFFT in, that there are pretty high rates of marijuana use, just with the question being asked this way. And it's, in order to delve deeper, these are just some screening questions to assess the level of severity and then to provide the brief intervention. But more questions and delving more into the adolescent's use can be, conducted during the brief intervention. So any, modes of, administration or, context that they're using certain drugs, including marijuana, can be discussed at that point.
Okay. Another question about defining binge drinking, and it says, will the binge drinking definition, and this is when we were moving into sort of understanding what is binge drinking as defined for different groups for adolescents, It says, will the binge drinking definition change as dietary recommendations change?
Is this referring to there's a proposed changes to the if this refers to the proposed changes to the drinking levels? No. At this point, the binge drinking limits are set, but we took these from the NIAAA guidelines for alcohol use for adolescents. So we're just taking these guidelines from what's provided to us by the authorities in this area, and if more information, anything changes, we will then, I guess there'll be a pretty wide dissemination of this information, and at this point, we don't have any more information. This is all that we can provide at this time.
Okay, great, thank you. And another question here, how long or how many sessions does it usually take to get through the 6 questions and the parts of MI in the brief intervention?
Hi, the brief intervention itself can be done, and I've seen it in the videos that we use in training and we put out there. And we aim for the actual time frame is anywhere between 5 and 15 minutes. Again, this is a brief intervention. It is very focused, even though I went question by question, step by step. It's really meant to go fairly quickly. If you need to do longer than that, and again, it depends on the individual student, your ability and their ability to connect and go through the steps. But again, as a brief intervention, it's meant to be very time-limited, brief therapy. It's not meant to go much more than 15 minutes, and if you do need to do that, and my head's switching into the whole idea of billing and how this is set forth. Screening is usually done separately. Brief intervention is usually in 15-minute segments, and that's what a lot of this is geared towards. But it's not just for billing, it's that you're doing it in a fast-paced environment where everyone is saying, I don't have time to do this. So again, that is the focus of what a brief intervention is all about.
Great, thank you, Shirley. Okay, we have another question that has come in about, I think this is an interesting question, and given your experience in school-based health centers and other places, I think some advice might be helpful to everyone, particularly when we're talking about the stigma around these issues. So if doing SBIRT in school settings, for example, how do you bring adolescents back for several brief interventions without the student becoming identified as one who, quote, needs help and possibly stigmatized?
Well, our work is in school-based health centers, so the key piece here is that we're trying to make SBIRT a part of routine practice in school-based health centers. So students get called in for multiple things, at a school-based health center. So there should not be any stigma because no one knows what the student is going in for. They go in for annual assessments. They go in for sports physicals. They go in, if they're not feeling well. They go in for other things, if they have asthma or other, diabetes, other chronic diseases. They go in for monitoring, and they can go in for, reproductive services. So there's multiple, issues and reasons why students go in, and also it's just another room in a school, and they get a pass to come in. It could be in the middle of a class. So there aren't a lot of students walking around in the halls to see who's going in. And so it's really, the whole point is to make this a part of routine practice. And the other piece is that SBIRT is not just those for, problem substance users, but it's for everyone. So people should be going in and getting screened even if they're not using it all. Everyone should be screened. That way you prevent the initiation. So that it's just the whole idea that we also stress in our other settings as well is that these questions are asked of everyone and should be expected. So we try to reduce stigma in that case.
Great, thank you. And I'm glad we had such good time left for questions because we've really gotten some good ones here. And I'd like to ask you a few more and just remind folks that if you want to ask a question, you can use your questions pane over to the right. Just simply type it in, and we've still got probably at least, I don't know, 10 minutes, 5 to 10 minutes left that we can do questions before we wrap up. So let's take a few more. Let's see here. This is always an interesting question. I've gotten this one from time to time as well. The question is, do I understand correctly that the permission portion of providing feedback, the feedback segment, that the provider is offering to give the adolescent a, quote, safe way to drink? And they're referencing the low-risk guidelines for drinking. So the low-risk guidelines are not zero or abstinence. So is the feedback offering them, quote unquote, a safe way to drink?
I don't think that any of us would say to an adolescent that this is the safer way because it's low risk. I don't think that that kind of information is necessarily useful or helpful. I think that what we would be saying is my role as a doctor, my role as a nurse, my role as your counselor, my role as a social worker is to say to you that I do not support drinking by adolescents at any age, both from a professional point of view because I know that it will be very harmful for you. Your brain is still developing. I think it puts you at greater risk. I believe that it might cause you some permanent damage. But I'm here also to help you find a way to make choices about that. So I don't believe that any professional would say that or even necessarily support that this is a safe way to drink. I don't think that's a message that we'd want to make.
Yes, and one of the things that we're always very sensitive of from a policy perspective, and many of us are working in arenas where there are very clear policies around what the guidelines are, and I've never encountered an environment where the policy perspective is anything other than zero or abstinence, right? So we have certainly been seeing that as folks are working at adolescents in criminal justice or other settings, that in their feedback they pair, okay, this is what the recommendation is, and that recommendation is zero or abstinence, and they balance that with their role as a provider, giving feedback that is around low risk, or in some cases, some settings, they refer to that as reducing harm. And so I mention that because we have certainly run into that, and often providers are feeling pulled between what is policy and what, as a provider, I should be doing, and oftentimes we find that pairing the feedback together and presenting both is certainly an option. So that's a great question. All right, let's take another question. Do you have, the scripting? I can see the feedback coming in. The scripting is very useful, and yes, the PowerPoints are available, and you can download those PowerPoints to take advantage of looking at that scripting again and using that in the work that you're doing. By chance, Brett or Shirley, do you have like a one-pager or a two-pager back and front that a provider could have in front of them and use as a guide that has some of this scripting and walks them through these elements that you've been talking about. And so that's the first question. And let's say you did have that, or you were delivering all of this, including the screening tool and the brief intervention verbally. Is it appropriate to take notes during that time and jot down what the adolescent is saying? So let's take the first question about, do you have that sort of handout, that one-page handout? Let's start with that question.
Hi, this is Shirley. I'm glad you asked, because we didn't necessarily come up with this on our own. As I said, the model we use and the model we train comes out of the Brief Negotiated Interview ART Institute, Youth and Adolescent Brief Intervention, and it is the 6-step model that's being used. I know out of the BNI Institute itself, they have both a 4 and a 5-step intervention that can be used, and you can also find those on little plastic cards somewhere. But yeah, they actually do have a one-pager, both in English and in Spanish, and it takes you through each one of the steps from engagement all the way down to summarizing and thanking the client for coming in. We can definitely give you the links to those. And the other thing I would add to this is something that Brett mentioned, and we do, is that along with this, and I don't have it here with me now, is a training help. And it actually shows you how you would engage with the interviewer who's going to be using this, and give them feedback either during a session, if you are allowed to monitor them, doing it during your training phase, providing supervision is another way of doing it. So yeah, and we got that off the internet, and we do use that when we're doing our training. Second part, I believe you asked, is it okay to take notes? And I would say, sure, as long as you, again, respecting the adolescent who's in the room with you, and explain what you're doing and while you're doing it, and it's part of how you help to understand who they are. And again, in taking your notes, you may want to offer to say, and if you want to look at what I'm writing down, sure, I'll be happy to share that with you. Again, recognizing their autonomy, that this isn't any secret type of information that's going to be used for or against them, but keeping it open and available at a time, I think that could be perfectly well, as long as you explain what it is and ask if they have a problem with it and offer to share it.
That's great. If you would be willing to send those links to myself or Misty, we can make sure those become available on the website where the PowerPoints are posted. That would be terrific. Thank you. And Shirley, this might be a good question for you. Actually, either of you could probably answer it. But please provide an example of how you would proceed with the script if you have a client who responds no in terms of discussing his or her substance use. How would you respond if someone said no, they weren't willing to talk about their substance use?
I would react the same way I would with an adult who said, no, I'm not comfortable talking about it, and say, okay, I respect your choice not to talk about it at this time. And again, ask and offer, is there, providing the information that you do have a concern, and ask again on their next visit coming in, that you're probably going to be going over all of their records with them, and this will include some of that information. And hopefully at that time they might be willing to talk about it, and leave the door open. I say leave the door open and say, and if there's a time when you want to do it before then, before you have to come back in, just come in and we'll sit down and talk about it. Brett, would you like to ask me?
No, I mean, I think Shirley pretty much covered it. It's just that, you know, some adolescents aren't going to want to share the information, but for the most part, in our experience, we found that they are willing to discuss it. So just if they want to say no, you have to respect that. You can always, you know, encourage this, kind of reiterate what you've already been talking about, and if they still say no, then just respect that.
Yeah, thank you. Thank you. So another question, kind of similar to this lines about how to respond or recommendations to sort of handle situations where an adolescent may be ambivalent, may not see that there are really any consequences of the behavior. So do you have any recommendations on how to either respond or with students who really don't see any negative consequences to substance use or who have a low readiness to change? How might you approach that situation to help move them towards change?
Again, I would say the basic understanding is where the individual is with their readiness to change. You can look at the stages of change, and you know, maybe they need more information. My response would be continue with the open-ended questions, the reflections, maybe doing a little bit more on the what's good and what's not so good. With an adolescent, as an adult, you might want to do the little thing about, you know, put both of your hands out in front of me, and in your right hand, I want you to tell me the good things about what you're doing, and the other hand, tell me what's not so good. I mean, they may want to try that, or they may not. And if they're really not ready to be there, it might be okay to say, you know, be honest with them. It really doesn't sound like you're engaging in want to engage in a conversation, and I can understand that, you know, maybe it's a little bit too difficult for you to talk about. What do you think about that? And, you know, hopefully try to draw out from them by using your motivational interviewing skills where they are with it. And if they're flat out saying it's not something I feel like doing, then you probably give it a rest and see about having them come back in. But again, a lot of times it may be uncomfortable for them, and what you're trying to do is create a safe environment where they can explore that with you. And it might be more of an issue of confidentiality. Again, I don't know that. In some school-based health centers, there are very little protections, and it might be an exposure of that nature could cause catastrophic, you know, events at home, and they're trying not to do that. And if they don't see it as a risk, it might be just a question about, well, can you tell me what would be the riskiest thing about it or the least riskiest thing about it? Again, going to the client, if you truly believe that the client holds the answers, which I do, then getting them to explain it to you, I think, is about the best you can do right now. I hope that's helpful.
Yeah, no, that is. Thank you. Thank you. And it looks like we're getting about to the mark of having to wrap up, but I'll ask one last question, which I think is probably fairly brief. In your experience, do parents need to give consent before a student can complete the CRAFFT screening test?
It depends on the setting, and usually in a primary care, any setting covered by HIPAA, the student would not need it. In a school-based health center, the students need parental permission to enroll in the school-based health center, and that allows students to come in and get all types of services, including those for sensitive services, such as substance use services or reproductive services. You have STDs. So at the point of actually getting a CRAFFT screen, no parental permission is required, and the parents will not find out about it because it's covered under HIPAA, and as long as the parent has given the consent for the student just to enroll at the beginning of the school year.
Great, thank you. Well, we were able to get to many, many questions. There aren't that many left, but I'm sorry to say that we are getting so close to time, and we, you know, if there are things that we can answer, we'll try to do that through the chat box in the remaining time. But certainly we got to many, and overwhelmingly folks have really enjoyed this. Really appreciate what you presented today, and I think you can see that the value of the information you provide. I really feel like they've gotten some education and tools that they can take out into the field, and so we really appreciate that, and it's certainly what we strive for in our webinar series, things that people can do something with the information immediately. So in our last couple of minutes here, I just want to remind folks that on the hospitalsbirt.webs.com website, there's a page that is dedicated to this particular webinar. It'll have a description. It'll have information about the CEs. There's a CE quiz that will be posted after our webinar today. The PowerPoint slides are already up there and can be downloaded in PDF format. The recording will also be posted there for your enjoyment for here and until way into the future, and that will always be available for free, and you'll be able to obtain the free CEs today by completing your CE quiz and also completing a very brief evaluation form. You can see over in your chat box there's a link to it says, please complete the brief short survey. That link will take you to a very, very brief survey, and I can't stress enough the importance of completing that survey. The evaluation is critical to us being able to really bring you the quality education and presenters and content like you've had today and in the future, and so I can't stress enough how important that is. And you'll be receiving a follow-up email. We certainly hope that if you have a second, since we're a couple of minutes before closing, to take that survey immediately after and then go and complete your CE quiz. But if for some reason you have to run off to your next meeting or call, we're going to have a follow-up email that's going to go out to you that will have links to all of these materials. And just to remind folks that, again, all the webinars in our series this year and last year are all free. All those from last year are still posted and available to you. And all those coming up in the coming months will be the same. And there are a lot of other terrific topics. And if you joined a few minutes late, just to call your attention, this is obviously adolescence is a topic you're very interested in. We have another one coming up in April 15th, all about teens, and then again in August, looking at young adults and college students. And of course, there are many other very interesting topics along the way. So please take advantage of these and share this with your colleagues and let them know about these opportunities. And again, I'd like to thank everyone for attending, and I'd like to thank, in particular, Brett and Shirley for this terrific educational content today, and to Misty Story for facilitating our webinar. It's very nice to be able to work with such wonderful partners and have terrific presenters. And again, we want to thank the National SBIRT ATTC, NADAC, and SAMHSA for sponsoring this webinar and all the webinars with us in the series. So with that, I will say thank you, everyone. Please look out for the email, complete the survey evaluation and the CE quiz, and we look forward to you joining us on a future webinar.